تمام. بسم الله الرحمن الرحيم. السلام عليكم. We'll discuss the vertebral column, joint, and ligament. The vertebral column commences at cranial-cervical junction and terminates at the tip of the coccyx. Comprise 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 3 to 4 fused coccygeal. Its function to support body weight, protect spinal cord and nerve roots, serve as an access aid in posture and movement, anchor the rib cage in thoracic region, and site for hematopoiesis. The curvature of the spinal cord. Fetal spine flexed in smooth C shape is the primary curvature. Secondary curves develop after birth, so 4 curves are seen in the sagittal plane in adult. Cervical lordosis from 3, thoracic kyphosis T2 to T12 ranging from 20 to 40 degrees, lumbar lordosis from L1, L5 ranging from 20 to 40 degrees, and sacral kyphosis from lumbosacral junction to the tip of the coccyx. Deforming dorsopathies. The first picture is the normal curvatures. The second one, the kyphosis, is the exaggerated curvature of the thoracic spine. Lordosis, exaggerated lumbar curvature. And scoliosis is a complex abnormality defined as lateral spinal curvature with a acute angle more than 10 degrees, present as S-shaped spine in AB view, and has a rotational component as well. Cube angle measurement. Cube angle is the angle between two intersected lines drawn along the upper end plate of the upper vertebra and the lower end plate of the lowest vertebra of the structural curve deformity. Scoliosis severity from 10 to 20 degrees mild, the moderate from 21 to 40, more than 40 is severe. Features of the typical vertebra. The typical vertebra is composed of 2 main parts. Anterior cylindrical mass of bone called the body, composed largely of cancellous bony tissue covered by a layer of compact bone. The superior and inferior surfaces of the bodies are flattened and covered by a thin plate of articular hyaline cartilage and are known as the endoplates. Posterior part is a posterior ring-like portion called the vertebral arch, formed by 2 pedicle, 2 laminae that support 4 articular processes, 2 transverse processes, and 1 spinous process. The vertebral body and arch enclose a space called the vertebral foramen. In the articulated column, the vertebral foramina form the vertebral canal, which is small triangular in cervical region, in thoracic small rounded, and large triangular in lumbar region. The pedicles are short, thick processes that project posteriorly from each side from the superior lateral parts of the posterior surface of the vertebral body. The pedicles are notched superiorly and inferiorly so that adjoining pedicles are separated by intervertebral foramen which transmit the segmental nerves. The broad, flat laminae are directed posteriorly and medially from the pedicles. The spinous processes project posteriorly and inferiorly from the junction of the laminae in the posterior midline. The transverse processes project laterally and slightly posteriorly from the junction of the pedicle and laminae. Articular processes project superiorly and inferiorly from each lamina. Articular facet on these processes face posteriorly on the superior facet and anteriorly on the inferior facet. The part of laminae between the superior and inferior articular facet on each side is called the pars interarticularis. Here an axial section, axial CT scan through lumbar vertebra, which is the most typical vertebra, showing anteriorly the vertebral body and posteriorly vertebral arch composed from the pedicles, transverse processes, laminae, and spinous process. Cervical spine. Typical cervical vertebrae from C3 to C6 share common features, have a small transversely located oblong body with slightly elongated anterior-inferior borders. The spinous processes are short and have a bifid tips. The pedicle project laterally and posteriorly from the body. Laminae are narrow and thin. Superior and inferior articular process located posterior to the transverse processes at the point where the pedicles and laminae unite. Together, the processes form short, thick columns of bone called the articular pillar. The transverse processes arise partly from the lateral aspect of the body and partly from the vertebral are short and wide, perforated by the foramen transversarium, which transmit, except C7, the vertebral artery and vein as well as a plexus of sympathetic nerves. Here the vertebral artery and vein through foramen transversarium from C1 to 6. Small lips are seen on the posterior lateral side of the superior surface of the C3 to C7 vertebral bodies are the uncinate processes, with the corresponding pivot on the inferior surface of vertebra above, forming a small joint called neurocentral joint or oncovertebral joints. Atypical cervical vertebra. The first two cervical vertebrae are atypical in that they are structurally modified to join the skull. The seventh vertebra is also atypical and slightly modified to join the thoracic spine. The atlas C1 have anterior arch, which has an anterior tubercle on its anterior surface to provide attachment for the anterior longitudinal ligament, and a facet posteriorly for articulation with the odontoid process. The posterior arch have a posterior tubercle on its posterior aspect to provide attachment for nuchal ligaments. And a vertebral artery sulcus, which is a groove on the upper aspect of posterior arch on each side, just posterior to the superior articular process. The lateral masses are bulky and each bears a superior and inferior articular processes. The transverse processes project laterally and slightly inferiorly from the lateral masses. The axis C1 have a body and a posterior arch. The body have the odontoid process, which has anterior articular facet, and posterior articular facet, superior articular processes, inferior articular processes. Vertebral prominence C7. Its name is derived from its long, easily filled, non-bifid spinous process. Its foramen transversarium is small or absent and usually transmits only vertebral veins. Here a lateral X-ray of the cervical spine showing anterior arch of C1 with its anterior tubercle, C1 posterior arch, C1 posterior tubercle, C2 body dense, and here the body, C2 bar interarticularis lamina, spinous process, the transverse process of C7, and bar interarticularis, and finally the facet joint. Frontal X-ray of the cervical spine, showing here the facet joint between C4, C5, and the articular pillar margin and the transverse processes. Here the spinous process interposed over the laminae and the body, the on-site processes in pink, and the oncovertebral joint. The transverse process of C7 projected downward while that of T1 projected upward. Tricky view here showing number 8 showing the lateral masses of C1 and the transverse process number 3. The number 6 is the lower inferior border of posterior arch of C1 marked with the line blue. The 2 is the dense. 9 the body of C2. The 10 the 9 is the body. 11 the lamina. 10 the spinous process. 12 is the pedicle. Mid-sagittal CT showing the anterior ring of C1, posterior ring, and the dense and body of C1 in the posterior spinous process. Parasagittal CT showing the occipital condyle articulate with the lateral masses of C1. Here the coronal CT showing the lateral masses of C1 articulate superiorly with the occipital condyle and inferiorly with the C2. In axial CT scan, here the first section through foramen magnum and laterally the condylar process. The second one, here the anterior arch of C1 with the tip of odontoid, lateral masses and posterior arch of C1 and the odontoid process, the body of C2 and the posterior arch, the section through C3, body transverse processes with the foramen transversarium, laminae, and its bifid spinous process. The last section is through the C7, showing its body, its small foramen transversarium, the laminae, and its long prominent non-bifid spinous process. Alignment of cervical spine, we have 4 lines. The anterior one is the anterior vertebral line along the anterior aspect of vertebral bodies. Posterior vertebral line along the posterior aspect of vertebral bodies. Spinolaminar line between the junction of lamina and spinous processes. The posterior spinous line connects the tip of spinous processes. Craniometry of the craniocervical junction. We have the prevertebral thickness should be less than 7 mm anterior to the C2 and less than 22 mm anterior to C7. The anterior atlantodental interval between the posterior aspect of anterior arch of C1 and the anterior aspect of dens of C2 in normal adult should be less than 3 mm and less than 5 mm in a normal child. Posterior atlantodental interval between the posterior aspect of the dens and the anterior aspect of C1 posterior arch, its lower limit should equal to 14. Lateral atlantodental interval between the lateral aspect of dens and the medial aspect of C1 lateral masses should be less than 2 to 3 mm side-to-side differences. Basin dens interval between the basin and the tip of the dens should be less than 12 mm. And we have 4 lines in respect to foramen magnum. Macerae line between the basin, macerae line between the basin and obthusion. The tip of odontoid normally project below. McGregor line between the posterior edge of the hard palate and the most caudal point of the occipital curve. The tip of odontoid should not exceed more than 5 mm above. Chamberlain line between the posterior edge of the hard palate and the obthusion. The tip of odontoid project not more than 2 to 3 mm above. And lastly, Buckingham line drawn along the posterior aspect of the clivus. The tip of odontoid should be anterior or tangential to this line. Digastric line between the digastric groove of the occipital bone. The tip of odontoid normally 11 to 12 mm below. bimastoid line between the mastoid processes. The tip of odontoid should not project more than 10 mm above. Transitional vertebra. In atlanto-occipital junction, it's present as atlanto-occipital assimilation with complete or partial fusion between the atlanto-occipital joint or pseudoarthrosis between the transverse process of C1 and the occipital bone, as shown in this section below. Or present as occipital vertebra as additional bone between the anterior arch of C1 and the occipital bone, called the third condyle. In cervicothoracic junction, present as cervical rib, bilaterally or unilaterally, as shown here in the coronal section. Bilateral cervical ribs arise laterally from C7, also in this axial section. Thoracic vertebrae. The body of thoracic vertebrae increase size from the first to the 12th vertebra. The articular facets are found on the anterior surface of the transverse processes for the costotransverse articulation. The facets on the articular processes are relatively vertical. The posterior lateral margin of each thoracic body have a costal facets for articulation with the heads of the ribs. T1 has a complete facet superiorly and a demifacet inferiorly. The bodies of the second through the 9th thoracic vertebrae contain demifacets superiorly and inferiorly. The 10th thoracic vertebra has only a superior demifacet. Finally, the 11th and the 12th thoracic vertebral bodies have a single complete facet at the superior margin for articulation with the 11th and 12th ribs. Here, lateral and AB X-ray for the thoracic spine showing the normal alignment and the normal disc spaces. More magnified view showing the part of vertebral body before the pedicle, F the intervertebral foramen, SP the superior articular processes, and here the pedicle and the vertebral bodies. Here axial CT through the thoracic vertebra showing the vertebral body, the costovertebral joint, and the costotransverse joint. In the axial CT scan, here they're showing anteriorly the vertebral body. And here superior and inferior articular processes, lamina posterior and spinous process. Here the intervertebral foramen and the costovertebral and costotransverse and the costovertebral joints. Lumbar vertebra have a body and a posterior arch. Articular facets face each other in sagittal plane. The mammillary process is a smoothly rounded projection on the back of each superior articular process for muscle attachment. The accessory process is at the back of the root of the transverse process, also for provide muscle and ligamentous attachment. Here, lateral and frontal X-ray of the lumbar spine showing the normal alignment and normal disc spaces. The spinous processes in yellow and the pedicle in red color. In more magnified view, here the pedicle and the transverse processes and the spinous process in yellow color. And here the parts of the vertebra. Oblique view of lumbar spine with the Scotty dog sign, where the I is for the pedicle, its mouth for the transverse process, the superior process, the foreleg for the inferior articular process, the neck for bar interarticulars, and the body is the lamina of the vertebra. The tail is the superior articular process of the opposite side, and the hind leg is the inferior articular process of the opposite side. Pre-colum model of TENS for the assessment of alignment of lumbar spine. It's divided into three columns. Anterior column comprise the anterior two-thirds of vertebral body and the anterior longitudinal ligament. The middle column is the posterior one-third of vertebral body and the posterior longitudinal ligament, and the posterior column for the posterior elements. Here, axial and sagittal CT section showing part of the lumbar vertebra. Thoracolumbar junction transitional vertebra present a 13 rib of the lumbar rib. Its supernumary rib project bilateral or unilaterally from L1 vertebra. The sacrum. The sacrum is formed by fusion of 5 sacral vertebral segments into a curved triangular bone wedged between the iliac bones of the pelvis, with its broad base directed obliquely superiorly and anteriorly. The sacral vertebrae may be partially separated by a rudimentary fibrocartilaginous disc. The superior surface of the base of sacrum articulates with the inferior surface of the last lumbar segment to form the lumbosacral junction. S1 has a superior articular processes which articulate with the inferior articular processes of the last lumbar vertebra. S1 body protrudes anteriorly as the sacral promontory. On each side of the sacral base is a large wing-like lateral mass called the ala. Laterally, a large articular facet for the articulation with the pelvis in the sacroiliac joint. Each of the anterior and posterior walls of the sacral canal is perforated by 4 pairs of pelvic sacral foramina for the passage of the sacral nerves and blood vessels. On the posterior surface, the laminae are seen to be fused. A sacral hiatus of variable extent inferior is caused by non-fusion of the laminae of S5 and often S4 in the midline. The inferior surface of the apex of the sacrum has an oval facet for the articulation with the coccyx. The fusion of the spinous processes for a median sacral crest. Fusion of the articular processes form a medial sacral crest. The transverse processes are rudimentary and fused to form lateral sacral crest. The coccyx is the terminal portion of vertebral column being formed by 3 to 4 individual vertebrae. It's attached to the sacrum by the fibrocartilaginous sacrococcygeal symphysis, which allows limited movement between the two bones. Differences in the sacrum between the male and female. The width of the body of S1 is equal or less than that of the ala in the female and wider in male. The female sacrum is shorter, wider, and more posterior tilted, thus increase the capacity of the pelvic cavity. The articular surfaces of S1 joint occupies 2 vertebrae in female and 2.5 vertebrae in male. The anterior surface of the female sacrum is flat in the upper part and sharply curved forward in the lower part, whereas that of the male is uniformly concave. Lumbosacral transitional vertebra. The middle one is the most typical, with the sacrum formed with the 5 fused sacral segments. In lumbarization, there is failure of S1 to fuse with the rest of the sacrum and separated from it by intervertebral disc. The number of sacral foramina is reduced to 3. In sacralization, there is a fusion of transverse processes of L5 with the sacrum, so that the number of sacral foramina increase unilaterally or bilaterally. Here, lateral and frontal X-ray of the sacrum showing L5 body and the spinous process, superior articular processes of the sacrum, the ala on each side, the sacroiliac joint, the foramen. and the promontory of S1 and the sacral canal. In lumbarization, there is a failure of fusion of S1, as shown here in the frontal X-ray, and lateral one. In sacralization, there is fusion of L5 with the S1 and loss of intervertebral disc space. Any question before proceeding into joint and ligaments?
شكرا دكتورة إيمان، عاشت إيدك. أكو أحد عنده سؤال على الفيرتبري، شرحة السيرفايكل والثراسك واللمبر والساكرا، قبل ما نروح على
Joint and
الجوينت؟
ligament.
ماكو، كلكم فهمتوها؟ أوكي، يلا تفضلي.
Joint of vertebral column. The occipito-atlantal articulation comprises two synovial joints formed between the occipital condyles and the superior articular surfaces of the lateral masses of C1. The atlantoaxial articulation comprises four joints, two lateral joints between the lateral masses of C1 and C2, two median joints, the dense anterior arch of the atlas, and between the dense and transverse atlantal ligaments. These joints are strengthened by the apical and alar ligaments as shown here in pictures, which join the tip of the dens to the margin of foramen magnum, and the cruciate ligament or cruciform ligament has a transverse band attached to the atlas and a vertical band from the posterior aspect of the body of axis to the margin of foramen magnum. Here a superior view showing the alar ligament and the transverse and vertical bands of the cruciate ligament. Posterior to those ligaments, the membrana tectoria is an upward continuation of the posterior longitudinal ligament from the axis to the anterior margin of foramen magnum, posterior to cruciate ligament. In coronal CT, showing the atlantoaxial and atlanto-occipital joints. In mid-sagittal CT, showing the median atlantoaxial joint. In parasagittal CT, showing the lateral atlantoaxial joint. Short clip showing the movement at the atlantoaxial joint. Neurocentral joint of Luschke, formed by two uncinate processes, point superiorly from the posterior lateral aspect of the superior end plate of C3 to 7 to articulate with the inferior end plate of the vertebra above. Are not a true synovial joint, each enclosed by fibrous capsule that is continuous medially with the corresponding intervertebral disc. So the degenerative changes that it's affected by the degenerative changes that affect the related intervertebral disc. Have minimal movement, and it's stabilized the neck by limiting the lateral flexion of the cervical spine. Here the uncinate processes with its forming the neurocentral joint with the end plate of vertebra above. The costovertebral and costotransverse joint. The costovertebral joint are paired synovial joint formed between the rib head and the costal facet of two adjacent thoracic vertebrae, the inferior aspect of the vertebra above and the superior aspect of the vertebra to which the rib corresponds numerically. The rib head also articulates with the intervertebral disc. However, the first and the 10th to 12th rib only articulate with the corresponding vertebra. The costotransverse joint are paired synovial joint between the facet on the posterior aspect of the rib neck and the anterior aspect of the transverse process. Here axial view through the thoracic vertebra, showing the costovertebral joint here and the costotransverse joint. The facet joints are paired joints extending from C1, C2 to L5, S1. The superior articular facet lies anterior to the inferior articular facet. The articular surfaces are covered by hyaline cartilage and surrounded by synovial-lined fibrous capsule. In the cervical region, the articular surface lies in the coronal plane with the oblique orientation from anterior superior to posterior inferior, allows strong coupling of the lateral flexion with axial rotation. In the thoracic region, the articular surface also lies in the coronal plane, apart from the T12L1 facet, which lies in an oblique plane. In the lumbar region, the articular surface is curved with the superior articular bosses facing posterior-medially and the inferior facing anterior-laterally. Facet tropism is a normal variant occurring most commonly at L4, L5, and L5S1, referring to asymmetry in the sagittal orientation of the facet joint at the same level as shown in this axial CT scan. On the right is the normal facet joint with the curved orientation, and then on the left side it has a coronal orientation. Here's a short video showing the movement on the facet joint, axial, lateral flexion. The sacroiliac joints are two synovial joints formed between the articular surfaces of the sacrum and the iliac blades on each side. Each joint is divided into superior posterior ligamentous portion and anterior inferior synovial portion. The ligamentous portion is formed by the interosseous sacroiliac ligament. The synovial portion is lined by a combination of hyaline and fibrocartilage cover articular surfaces and a synovial capsule. The synovial portion, further stabilized by the anterior sacroiliac joint, anterior sacroiliac ligament, posterior sacroiliac ligament, and accessory ligament include the iliolumbar ligament, sacrotuberous ligament, and the sacrospinous ligament. Here, coronal and the axial CT scan showing the sacroiliac ligament joint. Ligaments of vertebral column. The spinal ligaments are important stabilizer of the vertebral column, and being made of fibrous tissue appear as thin black strips on all MRI pulse sequences. The anterior longitudinal ligament extends from the basilar part of the occipital bone along the anterior surface of the vertebral bodies and intervertebral disc as far as the upper sacrum. Is firmly attached to the disc and less firmly to the anterior surface of the vertebral body. Extends superiorly as the anterior atlanto-occipital membrane from the upper border of the anterior arch of the atlas to the anterior margin of foramen magnum. Posterior longitudinal ligaments runs posterior to the vertebral bodies and disc from the axis to sacrum, being wider at the disc space and being firmly attached to the posterior annulus. Continues superiorly as membrana tectoria from the posterior aspect of the body of the axis to the anterior margin of foramen magnum. The posterior ligamentous complex comprises supraspinous ligament, ligamentum flavum, interspinous ligaments. Supraspinous ligament connects the tip of spinous processes of C7 to sacrum. Above level C7 is represented by the ligamentum nuchae, which runs in the midline sagittal plane from the external occipital protuberance and the external occipital crest to the posterior arch of the atlas and the cervical spinous processes. Ligamentum flava runs between the adjacent laminae and the bases of the spinous processes, continues above as superior atlantoaxial and atlanto-occipital ligaments. Interspinous ligaments runs between the adjacent spinous processes and appear relatively hyperintense since it's bordered on each side by fat. A relatively weak ligaments connect adjacent transverse processes is the intertransverse ligament. Here, sagittal MRI showing the sagittal CT, showing anterior longitudinal ligament with the lined by the pink color, posterior longitudinal ligament in purple, and interspinous ligament and supraspinous ligament in light pink color. Here showing the in the cervical region, sagittal MRI showing anterior longitudinal ligament continuous above as the anterior atlanto-occipital membrane, and the posterior longitudinal ligament continuous superiorly as the tectorial membrane. Cruciform ligament in pink, and in dark pink the apical ligament. Ligamentum flavum in yellow. Posterior atlantoaxial membrane and posterior atlanto-occipital membrane superiorly in orange color, and supraspinous ligament and the nuchal ligament in green. Any question?
عاشتي دكتورة إيمان. She
شكرا
finished
أستاذ.
the ligaments and joints of the vertebral column. أكو أحد عنده سؤال قبل ما نروح على الكويز؟
عفوا دكتور أنا عندي سؤال.
تفضل.
In the thoracic region of the spine, as we go from T1 to T12, is there any change in the interpedicular distance?
دكتورة إيمان سمعتي السؤال؟
أستاذ سمعته
إيه.
بس interpedicular distance ما
نعم
عندي فكرة
دكتورة.
عن interpedicular distance.
عيدي السؤال سولي.
The distance between the two pedicles, as we go from T1 to T12, does it increase, decrease, or it is still the same?
يعني أنا ما عندي معلومة عن هذا
يفترض ما يرضي
interpedicular.
انكريز. يفترض يعني خلينا نقول imperceptible increase. اكو increase بس not so prominent يعني. اكو there is increase وباللمبر طبعا بعد wider الانتربيديكولار distance.
اوكي شكرا دكتور.
عفوا. اكو بعد احد عنده سؤال؟ دكتورة ايمان يعني انت شلون السيدة ممكن تطلعي لنا دكتورة ايمان كورونال سي تي سكان بالثراسك through the pedicle اذا تقدري ترجعين؟
لازم أرجع سلايد.
ما يخاف على السريع. إيه؟
دكتور بلا زحمة أنا هم عندي سؤال.
ما يخاف بس خلي نشوف الكورونا هذه.
أنا ما أعرف أكو كورونا خلاني لو لا.
أعتقد بالبداية كانت
موجودة بالأخير.
هذه سيرفايكال. إذا طلعين ثراسك
ما أعتقد كان أكو كورونا براسك.
ارجع هذا، ارجع لقبله، ارجع سلايد قبل هذا اوكي، هذا كورونا. لا ارجع اللي قبله،
تمام
لا اللي بعد ارجع بالعكس هذا الاي بي واللاترال، لا بالعكس.
تمام.
حتى لو بلين اكسترا بنتي داريز اكو مايل.
هذا استاذ رعد.
ايه
فهسه اذا تشوفون من ننزل بالثوراسيك اكو زياده بالانتربيديكولار ديستانس.
اللي
يعني اذا تقارنون الجو ويا الفوق اكو فرق.
اي موجود طبعا اكو مايل، باعتبار كل ما ننزل لللمبر هي الفيرتبرات
سايز انكريز.
ايه اوكي. بعد منو عنده سؤال قال؟
أني دكتور. دكتور الساكرال هياتس هم نحسبها ضمن الفورامينات مالت الساكرم لو بس هذين الفور بيرز نحسبهن؟
يعني شنو قصدك؟
دكتور كان اكو MCQ أنا قريته فيقول إنه الساكرال فورامينا عددهن 4 بير وكاتبه خطأ، فيعني هي الساكرال هياتس هم تنحسب ضمن الفورامينات لو ما نحسبها هن بس 4 بيرز فورامينا؟
لا هن 5، هن مو 4 يعني. هن من 4 إلى 5، بس ليش قال خطأ قال 4؟
هو كان كاتبه 4 فورامين on each side وبعدين كاتب خطأ، بس ما حاط الإجابة الصحيحة.
ما أعرف، بس هي مو يعني أنا اللي أعرفه أن يعني 4 إلى 5 ممكن، بس يعني مو ذات أهمية هن.
أستاذ رعاد،
تفضل.
أنا هنا أستاذ أكو أخطاء بالكتاب الMCQ، أكو أخطاء ماكو يعني
طبعا موجودة.
موجودة.
حتى بريان اكو همينة اخطاء، وهذه يعني مو مهمة، هذه اعتقد مو كلش مهمة.
ماشي دكتور.
اذا خلينا نروح على شو اسمه، على الكويز.
طبعا هذا الفيديو عليك من يلا يقلب.
تقدرين توخرين الشو وتمشيهن كلهن، يعني ماكو مشكلة. بس حلوة، خوش صور واضحة، اعتقد غطيت لكم الفيرتبرال كولوم كلش حلو، و يعني خليت لكم illustration حتى فيديوز وهذه.
شنو صار؟
هذه هاوري دكتور هاوري.
نعم أستاذ. فهذا joint between the rib and vertebral body.
بلى يعني هذه which vertebra؟
The thoracic vertebra.
الراس الفيرتبرا. وش يصحوا لهاي الجوينت؟
Costovertebral joint.
costovertebral joint. اوكي. هذه طبعا الرايد دائما شو اسمه مصطفى عدنان.
نعم أستاذ. هذه right superior articular process.
شوية فيرتبرا وهي ترانسفيرز بروسيس، شو يصحوا لها؟ هذيك costovertebral هاي جوينت شرحتها هي.
Neurocentral joint.
مو costo transverse joint. علي سمير.
نعم أستاذ. جوينت بين الريب يعني بوستير سيرفيس مال الريب وبين الترانسفيرس بروسيس، هاي يسمونها كوستال ترانسفيرس جوينت.
بل
رايت. نعم
صحيح، الرايت وان. مريم حسين.
نعم أستاذ. هذا
الأبر
الرايت.
ستراكشر.
نعم الرايت intervertebral foramen.
رايت انترفيرتبرال فورامين. اكسلنت. لينا.
نعم. هذا الليفت نيورو سنترال جوينت.
نيورو سنترال جوينتس. هذه جوينت هاي لو فورامين.
فورامن.
فورامين. هاي الفيرتبرا which part which vertebra هاي؟ ثراسيك، لمبر، سيرفايكال، شو تقولين؟
ثوراسيك بير.
ثراسيك غلط. دلال.
بلي دكتور. هاي راي left foramen transversum. هاي lumbar mostly lumbar vertebra.
لمبر هاي؟
لا أستاذ.
دلال. اللمبر
بلي
بيها فورامن وش يفوت بيها هذه؟
العفو السيرفايكال دكتور.
سيرفايكال. الليفت.
left foramen transversum اللي يمر بيها الفيرتبرال artery.
مو صحيح؟ مقارن ويا دكتورة إيمان، ايش قد تعبانة على المحاضرة، بس انتم مقارن وياها ما متحضرين. هلا غالب.
نعم أستاذ. هذا الليفت نيورو سنترال جوينت أوفلوشكا.
أوفلوشكا. هذه يا فيرتبرا. هلا. تبارك. تبارك موجودة؟
نعم نعم أستاذ. يعني يا فيرتبرا.
اي يعني سيرفايكال، ثراسيك اور لمبر. السباعي هذا ستراكشر بنتي، مو التراكيا موجودة قدامك.
سيرفايكال.
سيرفايكال مو صحيح؟ وعادة الجوينت اوف لوشكاي موجودة بالسيرفايكال أكثر من غير مكان. نختار رسل نشمي.
نعم أستاذ. هاي right articular process.
right articular process.
لا. superior.
superior articular. اوكي. غادة.
نعم أستاذ. هذه الانفيريور articular process الرايت.
بل. تفضل أستاذ محمد.
نعم أستاذ. مريم شمال.
نعم أستاذ.
هذا شنو؟
هذا ال anterior arch of C1.
anterior arch of C1. نعم. محمد إبراهيم.
نعم أستاذ. هذا posterior arch of C1.
نعم. زين. علي عبد الجليل.
نعم أستاذ. هذا ال prevertebral space.
prevertebral space. نعم. عائشة.
نعم أستاذ. هذا posterior longitudinal ligament. I guess.
فاعلة. زين. هذا بعيد كلش. هي البوستيريور لونجيتودينال ليجامنت وين تصير؟
لا هناك البوستيريور. ما أعرف.
صفا عباس.
نعم أستاذ. This nuchal ligament.
نعم. ضحى نبيل.
نعم أستاذ. anterior longitudinal ligament.
شريهان.
نعم أستاذ. هاي interspinous ligament.
interspinous ligament. زينة مثنى.
نعم أستاذ. هاي C5 vertebral body.
زهراء حسين.
نعم أستاذ. intervertebral disc C6 C7.
رنا صادق.
نعم أستاذ. هذا spinous process of C7.
شكرا جزيلا.